Welcome back. Before we get started, I do want to remind everybody that at the end of Dr. Scher's session, Dr. Berry will be doing a Q&A with him. And if you have any questions down there on the bottom right-hand corner, you're going to see that little Q&A tab if you're on a regular computer. That's where he's going to pull the questions from. So that's where you can ask all of your questions. Now, like I said, kicking off today is Dr. Bret Scher, and he's going to be sharing with you on heart health on the proper human diet. And I'm super excited about this one. Dr. Scher may just be the most unique cardiologist that you're ever going to encounter. He graduated from Stanford University with a BS in biology in 1994 and then Ohio State University Medical School with an MD. That was in 1998. He completed a preventative cardiology fellowship at Scripps Clinic in San Diego and has been in practice for over 15 years, helping people reverse and prevent heart disease. He is a card-carrying, board-certified cardiologist and spent years learning the invasive procedures and the medications used to treat heart disease. Now, he tries to do everything in his power to make those multi-billion-dollar tools and drugs go unused. Dr. Scher's goal is to inspire individuals just like you and I to dictate our own health by adopting healthy lifestyle habits that allow us to achieve your best health ever. Having competed in triathlons ever since he was a teenager, fitness and health were always obsessions of his. In college at Stanford University, he was able to maintain daily training and focus on healthy nutrition. Then, all of a sudden, real life happened. He entered Ohio State University's medical school, followed by internal medicine residency at Mercy Hospital in San Diego, and a fellowship in preventive cardiology at Scripps Clinic. Suddenly, those gym visits, long runs, bicycle rides, they all became a real struggle for him to maintain. He found it really difficult to find time to eat well, stay active, and get enough sleep every day, and then handle the stress of a high-stakes job on top of that. Fortunately, he knew the importance of those habits, and he tried to maintain them, even if it was on a smaller scale. It's kind of like what Dr. Berry was talking about, just stand up and sit down twice instead of once. Upon starting his cardiology practice in San Diego, Dr. Scher encountered thousands of people who struggled far more than he did to maintain healthy habits. Some never exercised or paid any attention to their nutrition. It just wasn't how they were raised. It was what they hadn't considered was being important. Other people knew that they should be doing what lacked the tools and the support structure to implement them. As a result, our healthcare system is full of people who suffer from diseases that are completely preventable. Suddenly, Dr. Scher had a clear mission to empower all of his patients to help themselves, to empower them to make the best informed choices possible by everything from their food to their activity to sleep to stress management every single day. After all, the best way to treat somebody is to prevent the need for treatment in the first place. I am so excited to hear Dr. Scher and learn how I and my family members can experience natural health that comes from both daily healthy lifestyles. It is my great privilege and honor to introduce to you Dr. Bret Scher.
All right, thank you very much for that introduction. That was wonderful. It's a pleasure to be here with you today to talk about cardiovascular health on a proper human diet, because it's obviously a big topic on a lot of people's minds. But of course, first, my disclosures, no financial ties to pharmaceutical, diagnostic, or medical device companies. I am the medical director at dietdoctor.com, which is an online resource for low-carb lifestyles. And I do telemedicine consults at lowcarbcardiologist.com, and I get some book royalties. But before we start talking about cardiovascular health, we need to talk about health in general, because that's one of my underlying messages, is that we can get so focused on one specific aspect of health, one specific lab marker, one specific disease process, that we can miss the big picture. Because when patients come to me, this is what they want. This is the image they want, a life of happiness and vitality and energy. And this is, of course, what I want for them. It's what I want for myself, and it's hopefully what everybody here wants. But this is the image, this is the concept that I think our medical community really fails at. We really fail at trying to promote an overall healthy, vibrant life. And instead, we focus far too much on the specifics. So I didn't spend 14 years of my life in college and medical school and residency residency and fellowship, training to try and help people improve their labs. I mean, that's not a goal. The goal that I wanted is to help people live like this. But unfortunately, as I entered medical practice, this wasn't exactly what I was seeing. And I'm embarrassed to say it took me a number of years to sort of figure out why and change things, but at least I finally got there. But here's the thing, when I came out of my training, this is what I was trained, right? This is the way we are all supposed to eat. Reduce your fat, count your calories. And how many times do you have to write in somebody's chart, patient did not comply with lifestyle therapies, patient was unable to stick to his prescribed diet, the lifestyle interventions are not showing the benefits we need. And what's the next step? Prescription, prescription, prescription. Well, you can only do that so many times, or hopefully you only have to do that so many times before you can start to think, maybe it's not the patient's problem. Maybe it's not your fault that you can't succeed with this lifestyle. Maybe it's actually my fault. Maybe it's the message's fault. Maybe it's the whole idea. So it was a gross misinterpretation of scientific studies and scientific data that led us to this conclusion. And it was unpacking that, digging deeper and realizing how it's basically built on, these recommendations are built on a house of cards and simply for the majority of people don't work, because this is not a proper human diet. This is not how we evolved. This is not what our bodies are meant to eat. Well, quick review. So this was the picture I was talking about when I was trying to say, this is what I want for my patients, and this is what everybody should be striving for a healthy lifestyle. This is the way we were told to eat, which simply does not work. And fortunately, there is another way to eat. That's sort of where I've been. Sorry about the technical snafu there. So it took me a little while, but I was able to come to the conclusion that there are better ways to eat that don't fit necessarily what we're being taught. So that means we have to question everything we're taught, because let's be honest, the people change slowly. And when you've been taught something for 20 or 30 years, when a guideline has been saying something for 50 years, it's hard to reverse course. It's hard to say, I'm sorry, I was wrong. But that's exactly what we need to do with a fresh set of eyes. So, but here's the problem. I don't think anybody would argue that this could be a healthy way to eat, but this, oh my God, all of a sudden eat this way and you're going to kill yourself, right? That's the medical opinion for the majority of prevention and nutrition and cardiology. But this is far more in line with a proper human diet. So for the next 40 minutes or so, I'm going to walk through how we've been misled, but more importantly, I'm going to show you the only slide you need to see for understanding cardiovascular health, cardiovascular risk, and a proper human diet. We're going to spend a lot of time talking about cholesterol and LDL, because that seems to be the big hang up for so many when it comes to this diet. And we're going to talk about some studies, and we're going to see this in the broader picture of how you can evaluate this for your health, or if you're a clinician, how you can evaluate this for your patients. Because there's no question, the number one thing I see is confusion. I see it in the patients I see it in the doctors and the clinicians and the nutritionists I speak with, because there's so much confusion out there, and hopefully this will help cut through it. But to get started right off the bat, here is the number one slide, the only slide you really need to see when you're talking about low carb diets and cardiovascular health, right? Because we're told they're dangerous, but there's nothing on this slide that says they're dangerous. So hopefully you can see my cursor here. The light blue is the low fat diet, and the dark blue is the low carb diet. So we can see for body mass, better loss of body mass on a low carb diet. Abdominal fat. So if you're losing body mass, that's the mass you really want to lose, is that abdominal fat. Better on a low carb diet. Triglycerides. Look at this difference in triglycerides. There is nothing that can match this, even from a in terms of lowering triglycerides and raising HDL. So of course, this triglyceride to HDL ratio is a dramatic improvement with low carb diets. And that is strongly linked with metabolic health, strongly linked with degree of cardiovascular disease and early onset of cardiovascular disease. So to be able to improve that, and people don't talk about it much because our most popular medications don't even touch this. So that's why it's not talked about as much, but it's such an important risk factor, and low carb diets are the best treatment for that. Then there's this ApoB to A1 ratio. You can sort of think of it as an LDL to HDL ratio, only even more accurate. So there was a study, the PURE study, which was an observational trial that looked at 177,000 people. And what they found, just living their normal lives on multiple continents, and what they found was the one lab marker that correlated best with risk of cardiovascular disease was this one right here, the ApoB to ApoA1 ratio. And you can see the difference. The low-fat diet actually worsens it, whereas the low-carb diet dramatically improves it. And then, of course, there's a small LDL, which we'll talk about more, and the glucose and the insulin. So this is when you talk about assessing your cardiovascular risk on a low-carb diet or a proper human diet, this is the only slide you need. And actually, you can just get rid of that second part. When you're just talking about assessing cardiovascular risk, this is such an important slide. It doesn't matter. I mean, anything that improves your markers like this has got to be a benefit for the vast majority of the people. But yet we're told this diet is dangerous. We're told this diet harms us. We're told we should not comply with this diet. And that's just backwards and wrong. And this is part of the digging that needs to happen to really change our medical society, because this evidence is out there and it's hard to argue with. But the arguments, fat and cholesterol, oh my. What about all the saturated fat? What about the dietary cholesterol? What about your blood cholesterol? That's what we're told is wrong. So clinicians seem to be in this predicament of would you rather, right? So I've got two young kids, and frequently when I would come home, my kids would run up to me, my youngest one, and he'd say, Daddy, would you rather get eaten by a shark or bitten 10 times by a rattlesnake? And that's not exactly the image I want when I come home. So I'm a little taken aback. And I said, well, how about we talk about, would I rather go mountain biking through the forest with the sun coming through, or go running on the beach where all I can hear is those waves? And before I can even finish, he's gone off to torment the dog or torment his brother, because he realizes I'm not playing his game. But this is sort of like what physicians feel they have to do. Okay, maybe a low carb diet can help your blood sugar and your insulin, but what about the trade-off, right? What about the trade-off of eating all that saturated fat and what that's going to do to your cholesterol and your arteries? So they think it's a would you rather, but it turns out it really isn't. So this concern about saturated fat, the dangers of saturated fat. We recently reviewed this article at Diet Doctor, and it was an update from the Cochrane database of all the sort of what they call the updated randomized controlled trials on eating saturated fat versus not eating as much saturated fat, and what it means for your heart health. Their overall conclusion, by looking at all these studies, was whether you ate saturated fat or not, there's no difference in who lives or dies. There's no difference in who lives and dies from heart disease, let alone who lives and dies overall. There was a very small increased risk of developing heart disease the more saturated fat you ate. Okay, then they unpacked it even further, and they said, well, when you look at the studies that controlled for what it does to your LDL cholesterol, if you ate the highest amount of saturated fat, but there was no change in your LDL cholesterol, then there was no impact on cardiovascular disease. So it's clearly not the saturated fat itself that's causing the problem. But if you ate the highest amount of saturated fat and it raised your LDL, that's when you saw this small increased risk of cardiovascular disease. Again, no change in who lives or dies, just a small increased risk of cardiovascular disease. Okay, but then you have to unpack that even further, right? We don't eat saturated fat, we eat food. So is it the same for people who eat a steak salad versus people who eat a big sandwich with some meat and cheese and a whole bunch of other processed junk in the bread and the sandwich, right? Those are both considered saturated fats. This study doesn't look at that. We don't eat saturated fat, we eat food. But also, what else were these people eating, right? Vast majority of people in these studies were eating a high carb, high fat, high processed food diet, not the proper human diet. So does this study have any relationship to eating the proper human diet? Well, not really. It didn't look at it. But let's just say for a second, okay, let's assume that the study is correct and there's a small increased risk for those that raise their LDL. Well, then the question becomes, is LDL really a concern with a low carb diet or a proper human diet? And the answer is no. Well, probably not for the majority of people, because when you look at the literature, studies like this, a meta-analysis of over 1,600 people comparing carb restricted diet versus a low fat diet, and at 6, 12, and 24 months, there was no difference in LDL cholesterol, no difference. The big concern that so many cardiologists and preventive physicians and the American Heart Association that they tell you to avoid fat and saturated fat and avoid low carb diets because of your LDL, no difference at 24 months. And here's another one, that at 1 year, there was no change in ApoB. So you can think of ApoB as an even better marker than LDL. It's an even more accurate marker for cardiovascular risk than LDL. So there was no change in ApoB. And oh, by the way, the A1C decreased by 20%. The HDL increased by 18%, and 94% reduced or eliminated their insulin. Does this sound like a dangerous diet that we have to avoid? Of course not, but it's fighting that belief in that bias in medicine. And oh, by the way, they took this study and went even further, and they calculated their 10-year cardiovascular risk. Not only was it harmful, not only was it not harmful, not only did it not increase the risk, it decreased the risk, decreased their 10-year risk by 12%. And that was despite the LDL going up by 10%. So the LDL went up, but the ApoB didn't change. And that's the better marker. So when you ask, is LDL a true concern for most people following a proper human diet or a low carb diet? The answer is for the majority of the people, no. So how does it lower risk? Well, as I mentioned, there's no change in ApoB for the majority of the people. And as that study showed at Cochrane database, eating saturated fat, eating what likely will amount to a proper human diet with increased animal proteins does not increase risk unless you see a dramatic increase in LDL in that population. But here we see no change in ApoB. And oh yeah, the small dense LDL decreases by 20%. So I mentioned how that was important. Well, here's a study on the left-hand side here. You can see the quartiles of small dense LDL. So the top level, which has the highest risk of cardiovascular disease, is the highest quartile of small dense LDL. And as the small dense LDL decreases, so does the risk of cardiovascular disease. Whereas on the right side, when you look at the larger buoyant LDL, you can see they're all grouped together. All the quartiles are grouped together. So there was no significant increased risk as your large buoyant LDL increased in this study. So we do have to be honest and say not all studies show the same result on the right, but on the left, that the more small dense LDL you have, the higher the risk, pretty much conclusively shown consistently. And low carb diets can reverse that and lower that. And the ApoB to A1 ratio, the one that I mentioned was the most important blood test in that Pure study, decreased by almost 10%. The triglyceride to HDL ratio decreased by 30%. And then the VLDL, large VLDL, which is a particle we don't talk much about, again, because our drugs don't really target it very well. But it is a atherogenic protein that has an ApoB on it that is related to cardiovascular disease as well, and that decreased by 40% on this diet. So when we hear low carb diets are dangerous, I just really have to scratch my head, because if these are the results we're seeing, I don't see anything dangerous about it. But here's the problem. When you're reading the studies, when you're reading the headlines, when you're hearing people talk about low carb diets, how do you define low carb? So how low carb is low carb? Well, as I wrote back in last year, or in the beginning of the year at Diet Doctor, don't ask Harvard if you're trying to figure out the answer to that question, because Harvard School of Public Health wrote a paper that got a lot of attention about how low carb diets are associated with a higher risk of dying. Period, full stop. That was their conclusion. The media ran with it. Well, how did they define low carb in this study? 40% of your calories of carbohydrates, 40% or less of your calories were from carbohydrates, which means if you're on a 2,000 calorie diet, that's 200 grams of carbs per day. If you're eating a true low carb diet or a true proper human diet, you're probably eating 200 per week, maybe even less. But if your baseline is the standard American diet, standard Western diet, industrial diet, where you're eating 300 or 400 calories from carbohydrates per day, or grams of carbohydrates per day, then 200 grams, I guess that is a low carb diet by comparison. But the semantics matter, the definitions matter. So to take a study like this and think it applies in any way to a proper human diet is just a complete misuse and misinterpretation of science. So when we're trying to look at the studies, we have to know how they define low carb, because this isn't it. But what is it is that study I showed before with all those beneficial markers improving. So when you hear low carb is dangerous, if you hear low carb increase your risk of heart disease or dying, you got to know the definitions and don't ask Harvard. But now that I've gone through the data showing that for the most people, there is not an increased risk of LDL going up, increased risk of cardiovascular disease based on those markers. There is this subset of people called hyper-responders, where the LDL can increase dramatically. And usually it's in thin, fit, active people. Not always, it can be in a lot of different people, but Dave Feldman has coined the term lean mass hyper-responders to refer to these people. And so most people have probably heard of this. So I want to talk about a patient, a specific patient that I saw a number of years ago, to walk through how I can assess someone with lean mass hyperresponder and how I sort of interpret their LDL in context. So here's some of the details. She's a 53-year-old triathlete. She had been eating a keto diet for 2.5 years. She was 5'4", 120 pounds. And you can see her LDL cholesterol was 275, HDL of 86, triglycerides of 47. But as we look further in some of her markers, she had LDL pattern A, which means she's more likely to have the large, buoyant LDL and almost none of the small, dense LDL. Her fasting blood sugar was 97, which was interesting, usually her highest number of the day, unless she was doing a really hard workout. But her fasting sugar and her workout sugars were her highest. The rest of the time, her blood sugar was perfect. And you can see that because her insulin was low, and her HOMA-IR, which is a measure of insulin resistance or insulin sensitivity, was very low at 0.5. So these are very reassuring. Her pattern A and her HOMA-IR, extremely reassuring blood markers, along with her triglyceride to HDL ratio there, which you can see is fantastic. So what is her cardiovascular risk? Right, as cardiologists or as any physician, we're trained to now use this risk calculator. So we can calculate someone's risk and say, do you need risk reduction therapies? And to be honest, these are geared towards, do we give people statins or not, which I think is the wrong question to ask. But you can see it has some good markers in it: your age, your gender, your race, your blood pressure, and your cholesterol, including your HDL. But then whether or not you have diabetes, as if it's a binary thing and it says nothing about insulin resistance, whether or not you're a smoker, as if smoking 3 packs a day is the same as smoking, 6 cigarettes a day. So it's certainly got its problem. But here's the biggest point. You put this woman's values into this calculator, and it says this calculator only provides a 10-year risk estimates for individuals with LDL less than 190. It won't even calculate her risk because of this underlying assumption that any LDL above 190 absolutely needs to be treated, because LDL is causal for heart disease. This is the underlying overall belief in preventive cardiology and medicine in general, that LDL is causal for heart disease. Well, the way I like to say it is LDL is causal for heart disease. My dog loves to give me this look with the tilted head, like, what are you talking about? What do you mean LDL is causal for heart disease? And part of it is how we define this word causal. Because when I hear LDL is causal for heart disease, that tells me any amount of LDL is dangerous and is going to cause heart disease and needs to be eliminated, and by itself is such an important factor and marker. Well, what I find so interesting is the European Society of Cardiology came out with this paper to show how LDL is causal for heart disease. And this is sort of their main graph. And it is incredibly complicated. And here is LDL right here. And it shows transcytosis and influx into the arterial endothelium. And this is the causal pathway. But wait a second. Oh yeah, there's also genetic determinants. There's also hypertension and low shear stress and systemic inflammation and smoking and diabetes and oxidative stress and proteolysis and inflammasome activation and circulating monocytes and the cellular and humoral response. So you look at a slide like this and it blows my mind that anybody can say LDL is by itself the most important thing and by itself is causal when you have all these other factors coming in. So that's why I have to phrase it as, are we sure LDL is causal? Because what about all these other markers? What about the company it keeps? So here's a slide, which I love this slide, just for purposes of reminding me about the company it keeps. But this is Andreas Einfeld. He is the founder and CEO of Diet Doctor. And he's 6'7", and here are my kids. And they are clearly not 6'7". But the point of this slide isn't to show that Andreas is tall and my kids are short. The point of the slide is to say, the company we keep as people matters. We know that if we're around positive and uplifting people, that is going to translate to us. So when I'm working with Andreas at Diet Doctor, the world has endless opportunities. We can impact the lives of so many people and help so many people improve their lives, improve their health with low carb lifestyles. And just talking to him and brainstorming about what we can do is so positive, so energetic, and so mission driven that you can't help but feed off that. So the company we keep matters. And it turns out, through this long-winded sort of strange analogy, that the company LDL keeps matters as well. So here's a study, looking back at the Framingham Heart Study, way back in the 80s. And just to orient you, on the bottom here, this is sort of LDL, this is LDL going from 100 to 160 to 220. And then going back into the screen here is HDL going from 85 down to 25. Now, if LDL was causative and the most important thing, well, this entire row here would be incredibly high, because the higher the bars, the higher your risk of heart disease. So this whole row with the highest LDL should be through the roof, but that's clearly not what you see. And this whole row over here with the low LDL should be tiny with no increased risk. And that's clearly not what you see. Now, to be fair, the worst is the high LDL and the low HDL. But look at this, the low LDL, 100 or less, and the low HDL has a significantly higher risk than if you had the highest level of LDL, but still had a good HDL. And no difference in risk among those with high HDL, no matter what your LDL. So looking at a slide like this, right away, we have to throw out the concept that LDL by itself is causative, by itself causes heart disease and is the #1 risk factor. It's clear the company it keeps matters because the risk is modulated by your HDL. But that's not just a one-off study, there's more. So this is a look at the 4S trial. So that was a trial back in the day, one of the early trials looking at statins, at simvastatin, to treat people who've had a heart attack. And it showed a significant benefit, a significant decreased risk of recurrent coronary events, so another heart attack basically, for people who were treated with simvastatin. But if you look at it further and look on the right side here, for isolated increased LDL, meaning your LDL was high, but your HDL was not low and your triglycerides were not high, there was no significant difference. This tiny difference here was not significant statistically. Whereas if you look at the lipid triad, meaning those who had low HDL and high triglycerides, that's where you saw the significant difference. And to see it in graphic form here, the white circles and white squares are the difference for those treated with the statin who had the lipid triad. The black circles and the black squares, for those who had isolated LDL treated with a statin, there was no difference. So clearly, the company it keeps matters. Clearly, there's more involved than just the LDL. So going back to this slide to quote unquote prove that LDL is causative of heart disease, these last two slides show the company keeps matters. So all these other things, the diabetes, the smoking, the inflammation, the genetics, the immune response, all these things play into it to such a great degree that we really have to question whether LDL itself is causative. Now, clearly it's involved. No question it's involved. But is it involved more than any of these others? Or do we focus on it more because we have drugs to treat it? And how do we evaluate it for you? So if the studies in the world is focusing on the brown penguins or the gray penguins, and you are the blue penguin, maybe the data doesn't represent you. And unfortunately, if you're eating a proper human diet, turns out the data likely doesn't represent you because people in these studies weren't eating those diets. Now, unfortunately, we can get into this pattern of then saying, well, LDL must not matter at all, and we can completely ignore it. So I need to caution against that as well. While I certainly say we focus on it far too much and we need to interpret it in context, we still need to interpret it. So we need to dig a little deeper about what we mean. So if we're talking about getting rid of the other contributing factors, can we ever truly eliminate vascular injury and inflammation? We don't know. We can certainly reduce it. by lifestyle interventions with nutrition and exercise and stress management and sleep, we can certainly reduce vascular injury and inflammation. Can we ever eliminate it? Do we ever get to the point where it's gone so LDL clearly has no effect? We don't know the answer to that question. Is large LDL truly benign? Well, I showed this study earlier that on the left-hand side showing the risk of the small dense LDL. On the right-hand side, this study showed no real difference in cardiovascular risk, regardless of your level of your larger, more buoyant LDL. But there are some studies that do show a difference. So again, to orient you, the left-hand side shows the larger LDL, the larger size LDL. The right-hand side here shows the small LDL. And going back into the screen here shows in the back row is the higher number of LDL particles, or the higher ApoB, which is basically the surrogate for LDL. And towards us is the lower number. Well, as you can see, the worst place you want to be is the high number of small LDL particles. But if you look over here on the left side with the large particles, even though there's a much lower risk, as you increase the number of particles, the risk did still go up. Okay, so the point of showing this is to say not all studies are consistent to show zero risk with the large LDL particles. Of course, the caveat is it was this specific population following a low fat or a mixed high carb, high fat diet. So may not apply to everybody, but it does plant the seed to at least say, okay, LDL may still have a role even if it's a large buoyant. The other thing we have to sort of justify when we're evaluating LDL is observational, genetic, and drug trials all agree that LDL increases cardiovascular risk. Now that is pretty dramatic in the medical world, where you can have 3 completely different types of studies all agreeing on one thing. Okay, so observational studies show that there is a small increased risk in the general population, that the higher the LDL, the higher cardiovascular risk. Genetic studies show that those with like the PCSK9 loss of function mutation, which is what led to the development of these PCSK9 drugs, for those people who have that loss of function genetic mutation, they have very low LDL and much lower risk of cardiovascular disease. Interestingly, they don't necessarily live longer, but they have a higher risk of cardiovascular disease. So that's another point. And then of course, the drug trials, the statin trials, certainly for secondary prevention, reduce risk of cardiovascular disease and small reduction in those who live or die. And in primary prevention, many trials show a decreased risk of cardiovascular disease, but depends on your underlying risk. So these 3 different types of trials all agree on LDL. So we have to sort of correlate that with, okay, maybe we need to be a little more cautious in throwing out LDL, but we have so many reasons to say, well, wait a second, maybe these trials don't apply to us. So first of all, LDL has a purpose, right? It's not there to kill us. It has a purpose. So it's not that the LDL itself is dangerous. It's the environment. It's the system we put the LDL in that makes it go awry. So maybe if we can get back to our evolutionary genetics, get back to the way we're supposed to be living, all of a sudden LDL can serve its purpose without being part of this dangerous milieu or this dangerous systemic process. Also, there's no mortality benefit for a primary prevention LDL lowering. So meaning if you haven't already had a heart attack or a stroke or a stent or a bypass, for the majority of the trials show no difference in who lives or dies. Well, that's pretty important to know. And there's studies showing that elderly people with higher LDL actually live longer. So this is confusing because this is an observational trial, so it doesn't prove cause and effect. Could be a self-selection, those who had the more dangerous types of LDL or are more genetically predisposed who had already had their heart attacks earlier. So we're not in these trials. But it also shows that there are subsets of patients who do very well with elevated LDL. The key is defining who those people are. And of course, something I've been hinting at is none of this research, none of the things I'm talking about had anything to do with people following a proper human diet. So if you are following a proper human diet, you are outside of what has been studied, which, to be honest, puts doctors in an interesting position because you can take one of 2 approaches. You can say, well, look, we don't know for sure what happens in a randomized control trial and in a well-run trial for people on a proper human diet. So we have to default to what we know about LDL from all these trials and assume you're the same. That's one approach. The other approach is to say, well, we don't know what happens to people on a proper human diet with elevated LDL, and there's reason enough to believe it is different and less of a risk. So let's find ways to monitor you and treat you accordingly without assuming you're just like everybody else. Two completely different perspectives. And it's not that one is right or what is wrong. One is right or one is wrong based on the doctor's belief and the patient's beliefs, and talking together about what they think the best path forward is. So the problem is, though, not many doctors even get to this point to even think and analyze things, because it's guideline-based medicine. It's write your prescription and get out. And it's not necessarily the fault of the doctor. It's really a fault of the system. So what I hope is keep spreading this message to you, to talk to your doctors about it, spreading this message to clinicians, to get people to think a little more critically about this and say, what does this actually mean? All right. But without just beating LDL to death, I want to talk about the new kid on the block. And not, of course, these new kids on the block, because they're not so new. But neither is this. It's a lipoprotein, what's called lipoprotein little a particle. And here's a diagram by Siobhan Huggins. And basically what this diagram shows is it's basically an LDL particle, but with this long thing called a kringle, or the ApoB, or sorry, the ApoA. And that's what changes the structure of the LDL particle just enough so that it's taken up well by the LDL receptors. It's more likely to be retained in the vessel wall, and it also is more likely to lead to blood clotting. So definitely an increased risk. And here's just a graph, if you look down here, showing that the LDL risk is as high or higher, sorry, the lipoprotein little a risk is as high or higher than the LDL cholesterol. But we haven't heard much about it until the past couple of years, because there are no approved drugs. This is my slide for approved drugs for elevated LP little a. That's it, there are none. And that's why we haven't heard much about it, because we're so focused on drug therapy. Now they're developing these very new and are going to be very expensive drugs for LP little a, which may come out in the next couple of years, which is why we're hearing more about it. So it truly is a drug-free zone at the moment. But I'm glad we're hearing more about it, because it is an important risk factor. Tends to be genetically controlled, tends to not respond well for long-term dietary changes. Now, can respond actually lower with a higher fat short-term dietary intervention, but it doesn't change much with long-term dietary interventions necessarily. So it puts people in an interesting position of, well, if we can't treat it, what do we do about it? But it's important to know, because when someone has an elevated LDL, knowing your LP little a is important, because LP little a is counted as LDL in your basic lipid panel. And that's why I highly recommend people going beyond the basic lipid panel, because you want to know, is a large portion of that LDL LP little a or not, because that's going to change how you see your risk. So the important point of mentioning this is that you need to know your number. And there are things you can do about it, whether it's niacin or vitamin C or L-carnitine or proline or even PCSK9 inhibitors. They can all lower the level. Whether or not that reduces heart attack risk, we don't know for certain, but it can lower the level, so something to consider. Now, the other part, though, about evaluation, if you know your lipids, you know your metabolic health, you know your LP little a, you can learn more by getting your calcium score. So this is the calcium score you don't want. All that white on the screen is calcium in the wall of the artery. But for the first time ever, the 2018 cholesterol guidelines say to get a calcium score on people who are at intermediate risk, where it's not clear that you want to treat them with a statin, right? Because guidelines are all about using statins, using statins, using statins. Well, this was the first time I saw a guideline say, well, maybe we don't need to use statins because of this trial right here. This was a trial out of Walter Reed Medical Center, and it took people with calcium scores of 0, put half on a statin, half not on a statin. And there are supposed to be 2 curves on that graph, but you can see they're absolutely overlaid. There's no difference in who got heart disease or who didn't get heart disease with their treatment with a statin or not, with a calcium score of 0. So it gives us much more confidence if someone has a high LDL, eating a proper human diet with good metabolic health and a calcium score of 0. Where's the evidence that we need to treat that person with a statin? Well, now we're accumulating evidence that we probably don't need to treat that person with a statin, but of course it needs to be very individualized because there's more to it than just that. So when it comes to evaluating cardiovascular risk on a proper human diet or evaluating cardiovascular risk at all, you have to start with not just the LDL cholesterol, but the ApoB or LDL particle numbers, because those are the better measures. And those are going to help you separate out the LP little a, which you have to measure as well. So you want to get your ApoB and your LP little a, which I have there on the bottom, plus the small dense LDL, the ApoB to A1 ratio, and the triglyceride to HDL ratio. That is the starting point for your lipid analysis. Not the ending point, but your starting point. Whereas so often now, people are starting with just the regular lipid panel. And the reason for that is, well, statins don't really affect the small dense LDL. Statins may not improve the ApoB to A1 ratio or the triglyceride to HDL ratio. Statins don't change LP little a. And since we're in such a statin-focused medical community, that they would sort of shun getting these extra tests. But what about lifestyle? Well, I've just shown through this whole talk how a proper human diet can benefit the majority of these, maybe not LP little a, but all the others, it can absolutely benefit. So that's why you want to follow these, because your framework should be, how is lifestyle affecting my risk, not how are drugs affecting my risk. But we don't just stop with the lipids either. There's so much more. Measuring your glucose, if you can, with a CGM is the best way to do it. Your insulin levels are so important because we know that insulin levels can be elevated far earlier than your glucose. And it is really the canary in the coal mine to show that you are at increased risk, rather than waiting till your glucose is elevated and reacting to it. Seeing the insulin rise first and then knowing you need to make some changes, so important. Inflammatory markers like CRP, so important, because then you need to really broaden your scope of what you're looking at and what could be causing the inflammation. And of course, family history is important and may play a role in how you adjust your cardiovascular risk and the thinking of your risk. And coronary calcium scores, like I mentioned, so important. So we can't get stuck in this mantra that we hear from medicine that LDL is all that matters, because there's so much more in putting it in the proper framework. And of course, lifestyle in general. I talk a lot about a proper human diet and a low carb diet, but physical activity, sleep, stress management, social connections, all have been shown to correlate with lower cardiovascular risk when done appropriately. So it's not just a proper human diet, it's a proper human lifestyle, which, to be honest, modern society does not promote. Modern society does not value, but we need to value it and promote it as individuals to lead our best life. So when it comes down to it, we don't have to have this would you rather debate. Would you rather have metabolic health or good cholesterol? You can have the combination of those. And it starts by seeing your patients in this manner, seeing yourself in this manner, wanting to live a lifestyle that promotes your health, that promotes your vitality, and just promotes the life you want to live. And that comes with leading a proper human lifestyle. So thank you very much. And I look forward to answering some of your questions.
Thank you so much, Dr. Scher. It's always a pleasure to see you, even if it's only virtually. We've got a lot of questions. My shirt from the summit came in the mail yesterday. Very nice shirt, very luxurious fabric. But as you can see, I got the female cut. And so if you also got a wrong size or a wrong gender cut, then you need to email support@drberry.com. Now, that's not my email. I don't check that, so I don't send medical questions. But if you got the wrong shirt or you haven't gotten your shirt, they're on back order, they're coming. But okay, doctor, let's do some questions. Do you have a few minutes?
Yeah, absolutely. Bring them on. I'd love to have.
Excellent presentation. You always rock it. I knew you would. I want to ask a personal question first. You know, I guess it's been a year or two now, but the American Heart Association, the American College of Cardiology, came out with new hypertension guidelines or high blood pressure recommendations, and said, you know, everybody needs to be 120 or less over 80 or less blood pressure wise, or they need to be on a blood pressure medication. Now, the American Academy of Family Physicians did not adopt this new position. The U.S. Preventative Task Force did not adopt this. They say that's too low. You're going to put every adult in the country on a pill. Now, I don't think anyone from the American College of Cardiology has signed up for this conference, so you're safe to speak freely. without ramifications. What do you believe is a healthy blood pressure where an adult with otherwise normal risk factors is safe and does not have to worry about having a diagnosis of hypertension?
Yeah, that's a great question. And I think it's important to understand where this recommendation came from. So it basically was one trial, the SPRINT trial, where they randomized people to be treated to 140 over 80 or to be treated to 120 over 80, or, I forget the diastolics, to be honest with you, but it's basically 120 to 140 were sort of the groups that they were being treated to. And there was a small benefit to being treated to the more aggressive, lower number. And it was a small benefit in mortality and in cardiovascular disease. But the flip side was there was also more people fainting, more people falling, more people having kidney disease and more people having side effects from the medications. And it took many people over 3 medications to get down to that level. So I guess it depends on your mindset in approaching this trial. You can say there was a benefit. I'm not looking at anything else. I'm changing my guidelines because there was a benefit. Or you say, okay, there was a benefit, but at what cost? And is there a better way to sort of refine this rather than to say everybody has to fit this role? So, I guess you can see the approach that some of these institutions took by lowering their guidelines. So it comes down to a balance. So of course, everybody should have the lowest blood pressure possible. Everybody should have a blood pressure of 110 over 60, right? But what do we have to do to get you there? And what are the risks and the trade-off and the balances? So right away, if you're eating a diet full of processed foods, if you are overweight, if you are having high cortisol and high adrenaline throughout the majority of your day, then the treatment is not a calcium channel blocker or a diuretic. The treatment is, let's refine your lifestyle to get you living the way you're supposed to be living, which is likely going to lower that blood pressure. Now, if you are checking all the boxes and you're doing everything right, you're eating twice a day with no snacks, you're a healthy weight, you're eating a very low processed real foods diet, and you're managing your stress and you're getting your 8 hours of sleep and your blood pressure is still in the 140s, that deserves attention, right? It doesn't necessarily deserve a knee-jerk medication, but it deserves attention as to what else can be going on. There are things called secondary causes of hypertension, which I've uncovered a few of for exactly those patients. I'm doing everything right, and my doctor just wants to put me on a pill. Well, maybe what you need is an evaluation to make sure the arteries to your kidneys aren't narrowed, to make sure you don't have a hormone secreting tumor. I mean, these things happen and they're not common, but in that group who's doing everything right and still has high blood pressure, maybe that is the case. So I guess the point is we're far too quick to prescribe a medication rather than evaluating the lifestyle, and not just nutrition, the whole lifestyle, and then evaluating further if necessary to get down to a lower blood pressure.
Yeah, I love that you brought up secondary hypertension, because I can tell you as a primary care physician, that's often not considered at all. And they are definitely zebras. And the majority of my day is spent treating horses. There's no doubt about that. But I think, especially for the next question, a lot of people go on keto, low carb, carnivore, for blood pressure reduction. And it absolutely does give blood pressure reduction in almost every single person. But if there's anybody out there who's been doing good, clean keto, carnivore, and your blood pressure is still substantially high, not just a little high, but substantially high, you need to go see your doctor and say, hey, have you checked me for all the causes of secondary hypertension? Because there's a list that's known to doctors, but many times your family doctor is very busy and they don't have time to really sit down and go, I wonder if there's renal artery stenosis here or some of the other causes of secondary hypertension. I'm working on a YouTube video about all those right now, so you can go to your doctor with the list and say, do I have this? Do I have this? Do I have this? How do you know? So that, and so the next question is from Karen. I have been ketovore for 9 months. Diabetes is completely in remission, but I still have high blood pressure. I'm on 100 milligrams of metoprolol daily. What else can I do to reverse my high blood pressure? Or is it just more time needed to reverse it, or am I stuck with it?
Yeah, it's a great question. And of course, it's hard to answer for a specific individual because there's so much that's involved, family history being part of it. But also, what are you doing for exercise? Doesn't mean you have to go to the gym and pump heavy iron or run marathons, but what are you doing to stay physically active during the day? What are you doing about your stress management? There's no question that the people who white knuckle in traffic or start, even when they get upset, their cortisol, their adrenaline rises and raises blood pressure. There's no question people are chronically underslept, especially if they have sleep apnea. But even if they don't have sleep apnea and are only getting 5-6 hours of sleep per night, correlated with a higher risk of high blood pressure. So paying attention to nutrition, of course, is so important, but paying attention to the other areas of your life are also very important. And then making sure you're not on any other drugs or supplements that can raise your blood pressure, and then possibly getting evaluated for secondary hypertension, exactly like you just said, Dr. Barry.
Yep,
all those things are important. Yeah,
absolutely. And I actually, Karen, I would ask your primary care physician next time you see them, why did you pick metoprolol specifically? That's a pretty chunky dose of metoprolol, and you're almost certainly having some side effects from taking that. Now, if there's a specific reason you're on it, that may be appropriate. But if it's just, if that was their knee-jerk pick for you, I would ask about maybe getting on another blood pressure medication. Next, from Marjorie. What are your thoughts on the lean mass hyperresponder phenomenon? Thank you. If I am personally a lean mass hyperresponder, my last lipid panel, I had total cholesterol 350, LDL 250, but my triglyceride and HDL-C were exquisitely beautiful. So I guess I'm a lean mass hyperresponder. I may have FH, but probably not. Am I increased danger because of this?
Yeah, it's a great question. Hopefully I addressed some of that in the talk here. Yeah, so you brought up FH, familial hypercholesterolemia, and I guess I didn't mention that and probably should have. That is one important thing to determine if you are or if you aren't. Now, the majority of the people who are lean mass hyperresponders do not have familial hypercholesterolemia because there's no family history of high cholesterol or premature heart disease. And before you went on a keto or carnivore diet, your LDL was 110, 120, 130, something like that. That almost completely rules out familial hypercholesterolemia when it then goes up to 200 or 250 or whatever the case may be after switching your diet. So assuming that's the case, are you at increased risk when your triglyceride to HDL ratio is perfect, when your inflammatory markers are low, when your insulin and your glucose are perfect? And the answer is we don't know, right? And that you can look at that from two standpoints. We don't know that it's not harmful at all, but we also don't know that it is harmful. And the assumption so often is that it is harmful because we default back to the evidence we have, even though that individual situation is not included in that evidence. So do we have reason to believe it could be different? Yes. Do we have absolute proof that it's different? No. So that's where this really entails evaluation from a physician who is familiar with these concepts and familiar with how to follow somebody with this, how to evaluate somebody further, and how to counsel somebody about what your risks are and what your options are. And unfortunately, you're not going to get that at most contemporary medical clinics and big office practices.
Yep, absolutely. And if somebody didn't hear me say it yesterday, I have a YouTube video titled "How to Find a Low Carb Doctor Near You," and it has all the databases that I know of with the listing of low carb doctors, keto doctors, carnivore doctors, and Diet Doctor has an excellent database, dietdoctor.com, and I list that as one of, I think there's 6 different databases that I listed in that video. So you can find a doctor who understands. I mean, the average doctor doesn't have any clue what, if you say lean mass hyperresponder, they're going to be like, I don't know what that means. Okay. So
I didn't learn about that. I didn't learn about that in med school. What are you talking about? It must not
exactly
exist, right?
Right. Candace wants to know, do I really need to fast for a certain amount of hours prior to having blood work performed?
So do you have to fast before your blood work? So good question. Triglycerides are probably the main number one reason why you would want to fast. And to get an accurate triglyceride number, you probably should be fasting between 8 and 12 hours, somewhere in that range. Now, some people actually like to check postprandial triglycerides to see how high it goes up after certain meals. That's less common. It could be something some people follow, but really the majority of the time to get accurate triglycerides, you want to follow a fasting blood test. If you only care about a directly measured LDL, And there it's important to say directly measured, because a lot of LDL is calculated. And if they're calculating it, you use the triglycerides in that equation. So that will affect your LDL. But if it's a directly measured LDL or your HDL, you really don't need to fast for those. But if you want to know your triglycerides, and of course, if you want to know fasting insulin or fasting glucose, then yes, fasting is important for those blood tests.
Yeah, I totally agree. Tiffany is a cardiac nurse practitioner. So
Great.
Tiffany Wozni Cole. So guys, right here's a low carb cardiac nurse practitioner who's in the conference. So you can reach out to her. Maybe she's in your area. She's been low carb, high fat / keto for 5+ years. But her HDL has went down about 20 points over the last 3 years. Her LDLs had a slight increase. Her trigs went down by half, and her total stayed the same. Any thoughts on why her HDL went down while everything else kind of normalized?
Well, first, Tiffany, if you are a low carb nurse practitioner, I hope you are on our it's called Find a Doctor, but it's really Find a Clinician map at dietdoctor.com. And hopefully you've taken our CME course too, which is dietdoctor.com/CME, a free online 3-hour CME course about low carb. And then you can be seeing Diet Doctor website. And even better, share it with your colleagues, because this is what we need more people inside the medical institutions, especially cardiology, endocrinology, primary care, to share that CME course to get more people knowledgeable about low carb. So that's the first part. And thank you for your question. Now that's interesting with HDL going down, because of course it's usually not what we see. So I'd be curious if you're on other medications or supplements, which may be impacting that. Sometimes it can be just a genetic component that you naturally have low HDL, but to actually have HDL actively, go down is pretty uncommon. And I'd be interested in just learning more about the rest of your lifestyle, exactly what's in your diet, to try and figure out why that would happen. And, getting a broader assessment, just like we talk about LDL particle number and LDL size, you can evaluate that for HDL as well. So sometimes what you could see is people who have genetically high HDL, but sort of the smaller HDL particles, and then their HDL may go down a little bit, but the actual particle makeup of the HDL can change, just like with LDL. So I'd be wondering if that could have happened with you as well, but hard to know for sure.
Yep. I would worry about medications and supplements. I would also ask, are you doing more of a plant-based keto? Because I see the biggest HDL elevations with a fatty meat heavy ketovore, carnivore. And then also I would ask, have you become more sedentary, Tiffany, in the last 3 years? Because it definitely seems like strenuous exercise, lifting heavy weights, even body weight, will tend to raise your HDL. So that's an excellent question. Candace again wants to know, is there a test to figure out if I have an issue with clotting? As in if I clot too easily?
There are. Whether they really apply to people with no health problems, not on medications, is unclear, but there are some tests you can do. Like when we put people on blood thinners after stents, we can test how their blood clots. So you can get those tests even if you're not on the medications, to see how quickly your blood clots. You can look for certain genetic variations. Factor V Leiden is one, prothrombin gene mutations are another. If you have these gene mutations, that can make you more likely to clot. So most hospitals or medical clinics will have something in their electronic health record, which is called a hypercoagulable workup. And it's a series of different blood tests to say, are you more prone to clotting? So you can definitely get those, and it involves things like antiphospholipid, and it's a number of different blood tests. So there isn't just one test. There's sort of a panel of tests to assess your clotting risk. So it's something that can be done. If it's completely normal, does it mean you have no increased clotting risk? Well, not exactly, but it makes it pretty unlikely that you have any of the common reasons for increased clotting.
Yeah, the clotting cascade is exquisitely complicated, and I'm convinced that we do not know all the intricacies of the clotting cascade yet, but there is a panel of tests that will check for the most common ones. And for most people, Doc, I found that asking the question, have you ever had a blood clot in your life that was weird or unusual? 99% of the time, that's going to find everybody. Did you have a blood clot during childbirth? after a car wreck, you had, like I had this huge blood clot in my leg for no reason, you've probably got one of these conditions. But that's not a 100% test, but it's a pretty good test.
And you know what's so interesting though? We sort of lump blood clots into provoked or unprovoked. And so if you were on a cross-country flight and got a blood clot, that may be labeled as provoked. But is it really? Like just getting a blood clot on a long-distance flight, is that, oh, we don't need to worry about that, that happens all the time? No, it doesn't. That's still pretty unusual and probably still deserves a workup, even though that's considered a provoked blood clot. Yeah, so I think we need to maybe refine those definitions a little bit.
David says, will there be a way to download a copy of this presentation so I can take it and show it to my PCP? This is great. Yes, there will be, David. For the next year, you can print out Dr. Scher's slides and take them and shove them very lovingly and very respectfully into your PCPs.
And recommend dietdoctor.com/CME.
That's right.
I mean,
and tell your PCP, hey, you can get 3 hours of CME for free. Every doctor loves free CME. The only way CME is better than free is if it comes with dinner. So Claire asked, how long does it take to raise HDL? Are there any suggestions for optimizing my HDL?
Yeah, it doesn't take long. That's the good answer. If I've seen so many patients following a higher carb diet, switch to a low carb, high fat diet, and then start some resistance training, and HDL can rise quickly within weeks. Now, it may take months to see its maximum effect, but you can start seeing the change within weeks. And how to optimize it? I mean, look, we used to say exercise and alcohol. Well, now, if you're already drinking alcohol, that's okay, but I wouldn't start drinking alcohol just because of your HDL. It's exercise. When you're doing everything right with your diet, when you're eating low carb, higher fat, proper human diet, and your HDL is sort of stalled out, adding exercise, higher intensity or resistance training can help give you that extra boost with your HDL.
Yes, I love it. And again, I have seen multiple people raise their HDL just by upping their proportion of fatty meat that they eat on a daily basis. Diane said, I love this. This is a pet peeve of mine. Is there any benefit to taking Zetia? Just found out my mom, who is 88, is taking Zetia. Ugh.
Is there any benefit to taking Zetia? Well, I guess the answer is yes. In one trial, adding Zetia to a statin showed a very small improvement in risk of cardiovascular disease. So people already on a statin, again, people following a low fat or a standard American diet, adding Zetia to the statin in that situation showed a very small increased benefit. So, what is your mom's lifestyle? What is her diet? What's her HDL and triglycerides? What is her metabolic health? Will Zetia have a benefit in that specific situation? We need more information. But so the answer is there was one trial showing a benefit, but that is a far cry from saying it's going to help everybody.
Right. And there were several other trials that showed no benefit whatsoever. I totally respect Dr. Scher's opinion, but my opinion is if you're eating the proper human diet, Zetia is a worthless copay. It's a worthless potential drug side effect. Throw it in the garbage. It is stupid. Zetia is stupid. If you're eating anywhere near a proper human diet, literally, Zetia is stupid. Sorry, Doc. That's a little pet peeve of mine.
I love your candor.
Okay, let's see. Tina says, is ApoB checked on a regular blood work panel, or do we have to request it?
Yeah, usually you're going to have to request that. You're going to have to request ApoB because the standard lipid panel is a LDL-C frequently calculated, which is also a problem, and then HDL and triglycerides. And sometimes they'll give you a non-HDL, which is a simple calculation. But if you want an ApoB or an LDL particle number, that you're going to have to request because that is more advanced testing.
Yep. And if you're requesting it from your primary care provider, you're probably going to have to take some documentation with you, like what the hell is ApoB, because they're probably not going to know. Let's see. David says, any suggestions beyond the proper human diet to lower a significantly elevated CAC score? And David, his score was 3,700 plus.
Oh, wow. 3,700 is quite the score. So don't ignore that. That requires further evaluation for sure. But this is a great question that I probably should address in my talk, the lowering of the calcium score. So Personally, I'm not sure that's even a goal. I'm not sure that should be the goal, because when you look at what a calcium score shows and what it doesn't, it shows calcium in the walls of the artery. That's not what hurts people, right? That is a reaction to vascular injury, inflammatory response, healing response. But what it is it's a measurement that there has been vascular injury that happened. So it does correlate with increased cardiovascular risk, but that is not what does the damage and what causes heart attacks. What causes heart attacks is the plaque buildup in the middle of the artery, what we call the lumen of the artery, that then breaks off. So having calcium in the wall does not mean you have plaque in the lumen. It just means you're at higher risk. So what you want to prevent is the plaque in the lumen. So anytime I have somebody with a high calcium score, my mind does not go to lowering the calcium score. My mind goes to making sure there is not plaque in the lumen and that does not break off and cause a heart attack, which are two different questions. There are some people who have been able to show regression of calcium on their calcium score. And that's good. I mean, I think that's okay, but I don't think that's the goal. The other caveat, and this is one of my pet peeves, is if you're going to say I reduced my calcium score, you need to have somebody who knows calcium scores looking at the pictures side by side, because I've seen people who come in with a beautiful, pristine study and an awful quality study, and you try and compare the two. There's so many different technical problems with calcium scores that can happen with you get this beam artifact or this rim artifact, the heart rate's different. If it's measured at different parts of the cardiac cycle, you're not comparing apples to apples. So you basically, the answer is you need somebody to really evaluate it. But the more important answer is that probably shouldn't be the goal. The goal is to make sure that there's no progression of interluminal coronary disease.
Yes. One final question, Doc. That's all we have time for. Joyce says, is there a way to refuse a statin from my doctor and not be labeled as non-compliant? Now, I've got a great strategy, but I want to hear Bret's strategy first.
Yeah, you know, the way I like to approach it is to engage your doctor in as your advocate and as sort of like an experiment, and say, listen, doc, I want to look at other measurements of my cardiovascular risk, and will you work with me for the next 3 months, 6 months, pick a time frame for me to not take this statin, and let's look at other things and see how they improve, whether it's a calcium score, whether it's a carotid intermediate thickness test, whether it's the more advanced lipid measurements, whether it's your blood sugar and your insulin levels. Let's see what I can do to these other markers to lower my overall risk without taking the statin, and reevaluate at that point. So I think that's a good strategy, because it's not just no, I refuse. It's no, but will you work with me to be part of my team to help me find another way?
That's a beautiful, beautiful strategy. And if you really like your doctor and you want to keep them, that's an excellent strategy. My quick and dirty strategy is just tell them you're allergic to statins. If your doctor sees that you're allergic to penicillin on your allergy list, doctors are very afraid of allergy lists. They would never, even if you were dying of an infection treatable by penicillin, they would not give you penicillin in the office. And so when you go to a new doctor, just say, I'm allergic to statins, the whole class. And that will literally table the entire discussion. It's not your fault. You're allergic to statins, so you can't be non-compliant. You're allergic. You can't help it. Okay. That's it, guys. We're done. Thank you so much, Dr. Scher. I love getting your perspective on all this stuff. You're always very eloquent and also very even keeled. You're not just keto or die. You really talk about the evidence, and I love that about you. All right, guys, we're going to turn it back over to one of the two crazy ketos, Joe. I think Rachel must still be working for a living. Thanks a lot, Doc.
Wow, that was some incredible information. I love listening to all of these different presenters, and I really enjoy Dr. Berry and the way he just is going to tell it like it is, right? He's like, go tell your doctor, like, this is how it's going to be. I mean, it's just such incredible information. And I'm excited to be able to share some of those slides with some of my family members to be able to, people are so worried about their cholesterol and their heart and everything else, and show when you eat the proper human diet, a lot of this stuff is going to be fixed. I'm really excited about that. So our next presenter, I'm really excited about this one, is going to be Kim Howerton. Now, to attend her presentation, I'm going to show you guys how you can make your weight back over to the main stage, which is located in the tab or browser that is down below. Now pay attention, if you haven't been around for the last couple of days, you're gonna have to do this after each presentation because every speaker has like their own Zoom room. Also, if you have the Zoom app, you may see something a little different from what I'm going to show you. So simply go back to the browser or the tab that you launched the platform in, and you'll be able to make the switch there. So let me go ahead and share my screen. Again, it's here. So back over here on our screen, hopefully you can see it. We're going to have, once again, if you go back out to the lobby to go see Kim's thing, you're going to just hit the main stage. And then you're going to click right there in the middle, and you're going to see this little launch button, and you're going to hit launch, and that will take you over to Kim's session. So I'm going to go ahead and do that right now, and we'll see you guys in a few minutes over in the session.